So our first speaker this morning is Dr. Felicia Cosman. She's professor of medicine at Columbia and medical director of the CRC at Helen Hayes Hospital. She received her medical degree at Stony Brook, intern and residency at Columbia, and a fellow at Columbia in endocrinology. She's one of the best doctors, we know that already, and clinical director of the National Osteoporosis Foundation. And she's going to speak this morning on sequential combination therapy in osteoporosis.
Thank you, David, for inviting me to speak here, and thanks for coming to this symposium this morning. This talk is going to review the data concerning combination and sequential therapies for osteoporosis. And to talk about whether there's really a role now for combination therapy in any clinical circumstances. I want to just reveal my disclosures. I have a number of relationships with various pharmaceutical companies, and some of the studies that I'll present today had some pharmaceutical funding and some were NIH funded. So you know, of course, that our current treatment paradigms that involve teriparatide include using teriparatide as a sole therapy in treatment-naive individuals, maybe 50% of the time. That's a kind of old quote, and I think it may be lower than that at this point, maybe 30% of the time, because we're kind of running out of people who've never been treated with any medication in terms of overall prevalence of the disease. And at least half the time or more, we're using teriparatide in individuals who've received prior treatment. And almost always, that treatment is a bisphosphonate or involves some use of a bisphosphonate. And almost always that bisphosphonate is stopped prior to starting teriparatide. People in general have had a kind of rationale against combination therapy over the years, and this is based on a number of factors, of course, more cost, more side effects with two drugs versus one, and also some very old data, some that came out of the Mass General group, but those were perhaps not so applicable to today's world because they involve 40 micrograms of teriparatide rather than 20, and the regimen was somewhat unusual, a 6-month lead-in period with a bisphosphonate rather than a long-term. So that was kind of somewhere halfway in between treatment naive and treatment established. So I think the argument against combination therapy really comes primarily from results of the PATH trial, which you're all familiar with. In this study, I'll remind you of the data here just by review, and I want to just concentrate on the pink versus the blue. So the pink bar is the PTH plus alendronate group compared to the PTH alone group. You're looking at spine on the left, total hip and radius on the right. And notice that the BMD increment with the combination group in pink is the same as with PTH alone for the spine. It's not lower, but it's not higher. You don't get additive benefit from the alendronate added to the PTH. But in the total hip and in the radius, the results are better than for PTH alone. And I think this hip difference is actually potentially very important, as I'll show you as we move forward in this talk. So just in terms of caveats about interpreting the data from the PATH trial, there was no additive benefit for the spine by DEXA of adding alendronate to the PTH, but there was no actual blunting either, and the only actual blunting we saw was looking at trabecular QCT data in the spine, and that is also fraught with some potential misinterpretation, because with change in marrow fat, which occurs when you give PTH, that can also artifactually elevate the apparent change that you see by QCT. So we need to be cautious about interpreting that. And remember that hip and radius BMD were superior with combination versus PTH alone. Then there are a number of other important considerations, namely that